And before I begin to actually speak officially, I would like to pay my respects also to the traditional owners that Mr. Newman referenced. Thank you very much for that kind welcome. In preparing to speak to you, I have had cause to pause and reflect on the now decade-long journey of the Australian Machado Joseph Disease Foundation. I wanted to share our journey in pictures and thoughts rather than slides that were heavy with facts and figures, because more than anything else, we are an organisation that prioritises the personal. The journeys of our clients navigating this disease are what has driven the development of our programs and our services. And so I had planned to share with you today beautiful faces of people who are no longer with us, but who have shaped who we are and who drive what we do. It's customary where we are from to make mention of this and to acknowledge that there are images of people who have departed in a presentation, but that they have been included with the express consent of their family. Many of you will have been part of the Cairns Australian Machado Joseph Disease Conference held in 2015 and will know that it was there that we felt renewed urgency to reach out and be part of the global Machado Joseph Disease community. It is easy to feel isolated, not just in a little country at the end of the world, but in the most remote and inaccessible parts of that little country. So these meetings are vital to help to connect and inspire all of us. At the 2015 conference, Professor Georges Sequiras very eloquently told the story of Machado Joseph disease around the world, using both his personal and medical and historical information. And although he was not able to be with us today, I feel honoured to have been able to again share his thoughts as he reminded us of the journey of which we have all been a part. For those of you who are not familiar with the Australian Machado Joseph Disease Foundation, we are a not-for-profit charity operating mainly in the northern parts of Australia, providing services to Aboriginal Australians who live with Machado Joseph disease. The foundation was started on Groote Island, which is a small island in the Gulf of Carpentaria, in the northern part of Australia, and apologies for not having the map to show you that today. The foundation was started basically out of desperation. At the time, there were very limited and completely inadequate disability and care supports available to anyone with a disability in the region, but it was particularly bad for families who lived with Machado Joseph disease. Some families were struggling with multiple symptomatic generations, and I'm sure that's something others of you will be familiar with. Local Anandiliagua leaders, chief amongst them Gayangwala Lara, who's with us this week, and her nephew Tony Wiramaraba, the president of the Anandiliagua Land Council, worked together with visionary public servants such as our own chair Neil Westbury to secure funding from the Aboriginal Benefits account, and it was this funding that allowed the foundation to be created. I was fortunate enough to have been raised in one of the communities on Groote Island and to know the families well, and together with our now CEO Nadia Lindop, formed a very small initial crew of 2, the sum total of the MJD Foundation, in late 2008, with a goal to improve the living conditions of families with Machado Joseph disease. It's safe to say that the growth of the MJDF has been entirely unanticipated. Nadia and I often joke that as busy mothers of young children in 2008, we felt that this was to be a fulfilling part-time occupation. We certainly did not anticipate that a decade later there would be families in 15 communities receiving care from over 30 staff, and our jobs escalated to something far more than part-time. That's because we were not to know that the same urgent needs felt by the Groote Island families were also being experienced by other families across the region. At Nooka, at Yirrkala, Galiwinku, Owen Pelly, Central Australia, and later in Darwin and across into far north Queensland. And over the past decade, the foundation has gradually expanded services into all of those communities. So why was there such a need? It's no surprise to anyone in this room that people living with Machado Joseph disease require high levels of support. The disease is cruelly disabling, particularly as it progresses. Generally speaking, Australia has what is internationally regarded as very good socialised health and to a lesser extent disability care. And from an international perspective, that is true. However, in these isolated and remote regions, successive governments have struggled to resource services adequately. The major barriers being related to the costs of remote service delivery, harsh weather, and sparse populations, resulting in very limited infrastructure. Many of the remote communities are accessible only by air for at least part of the year due to flooding wet seasons, which means that freight needs to come by air or water, substantially increasing the costs of doing anything. One of our earliest supporters, and now patron, Professor Garth Nicholson, commented that it was a case of taking one of the most long-lasting, highly disabling conditions known to man and manifesting it in some of the most inaccessible places on earth. And so there were some challenges ahead. Some of them were related to the physical, the weather, the lack of infrastructure, the lack of locally available skilled health and disability care workers, entrenched social and economic disparity. And some were related to less obvious barriers. Machado-Joseph disease is, as you know, genetic. All of the people living with the disease or caring for people with it are families. And we learned very quickly that what is important was to support whole families. Guided by Gayangwa and other senior family members from each of the families, and with the experience of people like my parents who had lived and worked in remote Aboriginal communities over decades, the things that were important were carefully spelt out. Anything that we did needed to consider the culture, the language, and the worldview of families living with Machado-Joseph disease. Most importantly, it had to originate and be endorsed by them. This meant turning established disability program delivery on its head and instead asking what people themselves prioritised. It also creates the challenge of finding and describing the best treatments and therapies that are available and exploring them with families so that the choices that the families make are appropriately informed. In health speak, that translates to client-led services. In practice, there is much nuance and reframing. The people that we provide care to speak more than 7 different languages. English is always the second, third, or even later language, and yet every health and community service is framed not only in English, but oriented to the Western, biomedical, individualised culture. Aboriginal families have worldviews that correlate very poorly with this orientation. Decisions are rarely about individual, but need to be considered in the context of the entire family, and therapeutic priorities may or may not be in line with what we as health professionals consider best practice. In some cases, there are specific cultural obligations and prohibitions that need to be carefully considered. To dismiss or minimise them can lead to avoidance or disengagement. To deal with this, we practice a paired worker model. Our health and community service staff and our researchers work closely with Aboriginal family members employed as community workers who are able to guide, interpret, translate, and culturally broker where necessary, explaining, teaching, and growing the cross-cultural skills of the team. Machado-Joseph Disease Foundation services are inclusive of the whole family impacted by MJD, those who are at risk of developing the disease, their caregivers, and extended family are all our clients. Our programs comprise specialist community-based disability support and education, genetic care and education, social and emotional wellbeing programs, and case management. All of the programs are delivered within the community by allied health, social work, or nursing professionals working in tandem with Aboriginal community workers. Building strong relationships, recognising the powerful connection to ancestral lands, and conducting programs on country, that is to say on ancestral lands, and local delivery are key principles of how the MJDF works. We currently administer in 4 main domains: providing community services, improving education about Machado-Joseph disease to families, the community, and the health and disability services sector, and by engaging in and sponsoring research and advocating for clients at the personal, community, and wider level. Delivering services our way means that our clients are able to have the best access and control of services possible. It does, however, present challenges, Our community workers are family members and often also live with MJD, and so workers need to be flexible and adaptive. At a macro level, the landscape for disability service delivery in Australia has radically changed in the past few years with the introduction of the National Disability Insurance Scheme, and the organisation has had to develop new ways to ensure that its services remain client-focused and are best practice. Like many other places, we are dealing with an undefined cohort. We simply do not know how many more people will go on to develop MJD and will continue to need our services. And so we need to steward resources carefully and continue to work with families to understand genetic transmission and the choices that are available to them. We know that appropriately conducted community-based research is a powerful tool to give control to and empower people. There is very little precedent to guide the work of the MJDF, and therefore the research and education programs play a critical role. Experience has shown that the better informed MJD families are about an activity and its potential impact, the more time they are given to consider an issue, the more inclined they are to engage with that activity. It has been critical to develop relationships with families that are robust enough to consider the issues scrupulously and avoid gratuitous concurrence and subsequent disengagement. This has resulted in service models being adapted and recreated. Where there are no protocols and practice guidelines, it has been necessary to generate them. Today, you will hear from Jen and Joyce about how people with Machado-Joseph disease on Groote Eylandt want to be part of the physical activity that is so important to keeping people strong. And you will also hear from Beck and Ali and a team of Jungel researchers about how language, culture and worldview must underlie any attempts to develop adaptive and augmentative communication techniques. And from the other end of Australia, you will hear from the Macquarie University zebrafish team about the techniques and compounds that show promise to deal with MJD at the molecular level. We are grateful to all of you and look forward to learning about new developments, stories and theories, and feel privileged to be able to share with you what has been happening in our part of the world. Thank you. We do have a few minutes for questions. Yeah, if anybody has any questions.
So I would like to know, given that the experience that you have is very particular due to the context of the scientific community that you have been following, what part of that experience can you apply or can you use to other less specific MJD communities? So you've been dealing with a lot of things. Some of them are very specific, I imagine, but I am also sure that your experience can, help seeing some issues that can also help people that are dealing with other communities. So this is my question.
Thank you. And I think that probably this conference is a very good example of that. The things that have been the most useful have been collaboration and listening. So it's been, we say that we operate from a client-led perspective, but if we listen to the people who are living with this disease, and if we find out what their priorities are, and if we build our programs from that perspective up, rather than from the top down, we can be a lot more effective. And that's why it's so important to bring researchers together and to work with the therapists and the lab scientists so that everybody is understanding and bringing back to the families what the latest information is. So I think listening probably would be the short answer. I'm not good at short answers. So. Thank you.
Any other questions?
Thank you very much for the nice presentation. My name is Alina Mukoyan. I'm coming from Bloch. We are representing the clinical research, so we are that type of collaboration that you are looking for. Can you tell us what are the expectations from the pharma industry in this respect?
That's an important question, and one that I will take on notice, because we don't know yet. What we do know is that for our cohort, we need to do a lot of work with families to help them to understand how something like that might work. So I believe that we have some work to do maybe with pharma around the way that we explain what the outcomes might be, what the risks might be, what the engagement practices might be for any of that kind of research. I think that's absolutely critical that we do that. So that would be the main, yeah.
You might have explained us, and I missed that part, how big is your cohort of patients right now? You don't know everybody, but
That's right.
yeah,
And yeah, we haven't got a lot of very solid epidemiological information. What we do know is that we have just under 700 people at risk and a cohort of around about 130 people who are currently affected. It might be slightly lower than that, it might be 110. So that's what we're looking at in Australia. Yeah.
And have you done any clinical trial? Are patients willing to participate in this context?
We have done no pharmacological clinical trials. We are about to start a physiotherapy RCT intervention, and we have a physical therapy project that you will hear about shortly that's been done as a PhD project, but nothing with pharmacological compounds so far, no. Yep.
Manuela, do we have time for any more? Any other questions? We have time for one more. If not, I think we'll go on to the next speaker.